Welcome everybody to our Ontario network of CAPC and CPNP projects webinar session. Really pleased to have you here with us today. Really pleased to be coming together to talk about cultural safety in Black perinatal care. My name is Sydney and I'm the network program lead. And I would like to just start things today by acknowledging and giving thanks to the First Peoples and other Indigenous peoples of the territories where we work and serve for sharing this land and supporting us to continue the work that we do with families all across Ontario. And with me also today is Blanca Serrano, and I'm going to hand things over to her and she will introduce our guest speaker. So over to you, Blanca.
Thank you, Sydney. And I have these two cameras, so apologies. I'm trying to look at you, but it feels weird for me. Anyways, it's so great to be here today, and thanks everybody for joining us. We've had the great pleasure of collaborating with Mommy Monitor. Last year, they offered 4 sessions on Black perinatal health and the different topics that come with that. We learned a great deal from that, and the feedback was really excellent, and those that participated really wanted to know more. And so this year, Elsie and Shani from Mommy Monitor prepared these 2 great sessions for us, more focused on cultural safety as it's related to Black perinatal health. And then today is sort of that overview of those sessions that Elsie will provide. So I'm happy to be able to introduce Elsie. It's so great to have you and to get to hear, learn from you more on this topic. And Elsie is the founder, CEO of Mommy Monitor, and I'll let her tell us more about herself. Welcome, Elsie. Thank you for being here.
Thank you so much, Blanca. Thank you, Sydney. I just wanted to say first and foremost, thank you guys all for having me here today. I appreciate it. I think that our team is always excited to share more about the work that we do. For us, I think that the things that we do on a day-to-day basis that feels natural to us because we're used to it isn't necessarily something that's natural to everybody else, which is something we've understood. So we're always very excited to continue to share the information we've learned, the new research that's being shared in our space specifically, and just supporting all professionals in this space so that they have a better opportunity to really serve their clients that are Black and racialized, to ensure that they're really receiving the support that they need. So I always appreciate everyone who comes, and I appreciate being able to share with you guys today. So I'm going to be sharing my screen now. Can everybody see that? Yes, I'm just going to make it full screen.
Yes, looks
okay,
good.
Perfect. Perfect. Okay.
There you go. Yeah.
Yep. So today what I'm going to be going through is how we envision cultural safety in Black perinatal care. And what this is going to focus more so on is what's already being taught right now, what's being shared amongst those in the Black perinatal or Black maternal health space. So in the US, in Canada, and then some things historically that has been taught within cultural safety, and how we envision that and what that looks like within the Black perinatal health space. So I'm gonna try to go through all of this a little more quickly and try to create safe space for you guys to ask questions specifically or share if anyone would like to before the end of this, and in between some parts as well. But we're going to be looking at cultural safety, again, history. If anyone did the other sessions with Shani or even the sessions that we did last year, everything always begins with history. But I'm going to try to keep it as brief as possible. It's very important, but I also know that we've gone over it multiple times, and we can't go into it as extensively as we would like, obviously, because it's not a history class. So what we do want is to be able to share more so that you understand the context and the purpose and the association with history to the current state and the current experience that Black folks have with their perinatal health. And then we're going to look at one case study, an example from one of our clients at Mommy Monitor. And then we can discuss that specifically, that case study, which is what I'm hoping we'll be able to get to. So the PHSA defines culturally safe care as something that an outcome that's based on respectful engagement, that strives to address power imbalances that are inherent already within the healthcare system, right? So a space essentially where an individual who is with their healthcare practitioner who is Black or who is racialized, that healthcare practitioner recognizes the power imbalance of their interaction, of their relationship, and it works to create a space where that patient can feel safe while they're in there, right? And it sounds into, there's two different ways it sounds, right? It sounds almost like, okay, well, I can do that. You just be kind to people, you be good to people, and they'll feel safe in a space. But then there's the alternate side of this where the environment itself sometimes already is not safe. So how do we identify those things? How do we acknowledge those things? How do we identify the identity of the patient, this Black patient who's in the space, who they are, whether that be their ethnicity, their culture, their race, which is all different experiences for many Black people and many people generally. And how do we acknowledge also the history with colonialism and how that's impacted our systems, our institutions, our healthcare, the way in which care is practiced, and the way in which we engage patients, right? And all of these are things that we're going to be kind of exploring today, and a little bit more. So cultural safety comes from the Aboriginal community specifically, and they outlined really early on that what it is people having an understanding of one's own culture, acknowledging of the difference and requirements of caregiver and requirements. Sorry, I'm like that caregivers actively are mindful and respectful of differences. Sorry for the extra bullet point. That we're informed by the theory of power relations, like I said earlier on, and the experience of the recipient of care, right? And also understanding that the person who's providing care is not defining things according to their experience and their understanding. So a really amazing quote that was provided is the executive director of Indigenous Health talked about the fact that there are significant health disparities that exist for Indigenous peoples in Canada. And a lot of this is connected to stereotyping, discrimination, and a lack of understanding, and all of these things that end up resulting in an avoidance of care or unsafe care because of those experiences. And this quote speaks there are very many similarities to what the Black experience looks like, where we have a number of people who avoid care and avoid even practices connected to care or what their care provider is providing to them or telling them to do or instructions, because they don't feel safe in this space, because they feel like it's not connecting to whatever knowledge it is that they already know, and they don't engage it in the right way. And sometimes it ends up in a result where they're experiencing adverse health outcomes like we've seen in research. And if we think about all of this historically, it's connected to history, right? It's connected to slavery. And in Canada, again, we all know there was slavery here. This is just briefly looking at when it happened here and what happened. There's a lot more to it. It's a lot more thorough than this, but I just briefly wanted to very briefly go over it and just help us understand where we started versus when the last segregated school closed in Canada. And what was really interesting to me is another quote where they really described the fact that although formalized Black bondage was officially over, as in slavery being over, the meaning of Blackness had been consolidated under slavery. So although slavery, and this is directly connected to this idea of the systemic impact and institutional impact of slavery for the Black population. And although slavery is over, which we see more clearly in the history in the United States, because they talk about slavery being over and slaves still working for no pay for like home, for a place to stay and all that kind of stuff, right? So although slavery was over, the idea of Blackness and what a Black person is and who they are and what they represent was still very much ingrained in what people knew in society. So there was no way, so the experience, although they weren't necessarily being whipped every day, that experience still kind of remained consistent because what they saw a Black person to be didn't change. So we know that despite we already know that in Canada, right, Black Canadians share a lived experience of trauma that is intergenerational. So that's really important because that is telling us that there are generations of pain and trauma that's being passed down between and amongst families, historical, institutional, and it's personal, right? And that's connected to what we talk about. And I try to explain this in a way so that for the person who really just doesn't get it and they're like, I don't understand that. The way I try to break it down is that what happened to us historically, it's almost like stories and patterns and customs and ideologies that are passed down throughout society that continue to treat people the same way over time. And there's not a real change. The only thing that changes is how blatant or how in your face those treatments are. So in the past, historically, people could use the N-word outrightly, right? And be very just combative and just horrible towards Black folks that they saw even walking down the street, right? And we think about sundown laws, we think about all those other things and ways in which they policed the Black body and controlled it, right? And today, a lot of these things are still happening, especially in the South of the United States, but it's not as blatant, right? And that's why there are microaggressions, and that's why there are other forms of harm that happen to the Black community, right? But all of these things turn into an experience that's not just historical, but it's institutional. So it's embedded and rooted within our institutions, but it's also intergenerational because we're experiencing it. It's being passed down from family to family to family, but then it becomes a personal thing. So now in my lived experience as an individual, I'm now carrying this experience from generations that's historical, that I experience when I go into institutions, in the way that I'm treated, in the way that I feel in those spaces, and the outcome of those experiences. And now everything that I feel now is my own lived experience. And then it's passed on again to the next generation. So it's a cycle, unfortunately. But this hopefully helps you to understand why that lived experience and why it's so important to understand it and how it extends to healthcare and the health experience. So like I said previously, when we think about history, we think about what are the ways in which bodies were controlled, in terms of their reproductive health, right? And historically, we know that there was population control policies that were created by the government, by corporations, by private agencies, specifically to stop Black folks from having children. Slave owners, the way that they treated their infertile slaves like damaged goods, and the way that they practiced slave breeding, specifically the way that slave owners controlled the marital choices, right? So Black men were used as studs. So tall, strong Black men were used as studs that they rented out at different homes to create more slaves that had the same physical embodiment of that particular slave. So there was no room for the Black family to really grow. And this is something that extends and continues throughout history into the 80s, into the crack epidemic in the United States, where the Black family was really torn apart. We talk about the prison industrial complex and how the Black family was torn apart because of that. We talk about even in Canada, CAS, or all the ways in which the Black family has been separated and torn apart, and how that's impacted the entire experience that they have. But this quote as well I felt was really important to this context. And it just says that human beings make their own history, but they do not make it arbitrarily in conditions chosen by themselves, but in conditions always already given and inherited from the past. So this speaks directly to the experience of Black folks when it comes to history in healthcare. Although history was created, the experience that they have in history was created, and they had no control over that, unfortunately. And the conditions that came from that were inherited by us. And that also extends to our experience today. And if we think about history, we also obviously have to think about privilege and where that comes from and the sources of that. And this is all important because this extends to even the experience of care and why that looks the way it looks for Black folks, and specific types of Black people as well. So your wealth, your family, and it's interesting because all these sources of privilege are also directly connected to the social determinants of health, right? And the factors that impact our day-to-day lives and experiences, right? So it just shows you how these things are aligned, and it's not just having them or not having them. So it's not just about equality or equity, right? It's about the experience that's associated with that as well, and how that determines whether or not something is equitable and whether or not something feels like it's from a source of equality or fair. So the three forms of racism that are directly associated, because we talked about history and we talked about privilege very briefly, and I wanted us to talk about racism as well, because the main reason why healthcare looks the way it does is directly associated with racism, whether it be connected to something that's implicit or explicit, or whatever that experience looks like, it is racism. And again, like we said earlier on, historically, it's the institutionalized racism, it's systemic racism. These are things that are just rooted in everything historically, right? So the main forms of racism, and it's actually four, I apologize for that, is the internalized racism, the personally meditated racism, discrimination and differential actions, and institutional racism. And for Black folks in particular, a lot of this comes from anti-Black racism, which comes from attitudes and practices and beliefs and prejudices and discrimination that's directly pointed at people of African descent. So African descent meaning people from Africa, the Caribbean, people who are Canadian and consider themselves Black. So just anybody who considers themselves Black who's from the diaspora. And we realize that, and in healthcare, we've all learned over time that racism is directly connected to stress, the stressors that we experience because of the different factors that impact our day-to-day life, and the behaviors that we experience on a day-to-day basis impact our care outcomes. And we see examples of this where Health Canada talked about it specifically when it comes to perinatal care, that Black women's pain during the birthing process and how that was being questioned by healthcare professionals, and how there was this weird teaching that the black skin was more tough. And this comes from Marion Sims, who of course was a horrible person in history, who conducted some of the first gynecological experiments on Black bodies, to like that started, I guess, this entire really horrible reproductive experimentation on Black bodies. But then we also see other examples of racism that aren't as aggressive, but are noticeable, like the fact that most of our textbooks don't have stuff like this, don't have pictures of Black bodies giving birth, and that these are not things that we see. So there are different forms of racism and how we see it, but then we see it in another way, right? Where during slavery, and actually there is more I've been taught more recently, just learning about history, like the castration of Black men as a punishment for crime. When we think about even like during slavery, Black men, the reason why a lot of Black men in prison now and other men wear pants that are lower, it comes from slavery and the fact that slave masters would rape Black men and would pull their pants down and lower their pants so that people would know and identify them that they had been raped by their master as a way to control them. So like everything that we see, and it's so hurtful and sad to really think about it, but what these types of things that we see within the Black community don't come from like nowhere. It's not, sometimes things just seem like they're a fashion statement or they seem like a thing that happens, but everything is really directly associated with history, and unfortunately continues to be passed down and used today because of lack of knowledge and lack of education. But yeah, so there's, in addition to that, like we know that there was the economic crisis, and how that impacted like the increased sterilization of unfit Black mothers. We know about the welfare queens that they talked about, and the fact that Norplant was basically conducting also experiments on them to stop them from having children, which sterilized a lot of people. But then we also know as well that within the criminal justice system, Black women were penalized for being pregnant, especially during the crack era specifically, and that we know that if they kept their child rather than having abortion, they were put in jail. And again, the history of sickle cell screening and that entire experience, and the difference between that and Tay-Sachs, and how both kind of started off in a very similar space, having very similar genetic conditions, but how one community took control of it, how another community was not able to, and what that it looks like as well historically. So these are all examples of how racism within the Black experience, and their reproductive experience and their healthcare experience, how all of this is connected to all facets of the life experience of Black folks, and how that impacts them, and how it becomes not just an institutional thing, but a personal thing, an intergenerational thing, like how it really, you can really see how racism plays out throughout history within the experiences of people, and how it unfortunately becomes a cycle that continues longer than it should. And if we think about being within Canada, the intersectional experience of Black women and Black persons in Canada, it's like connected, like I said earlier on, to various different experiences, right? Whether it be whether or not you can keep your children, what your health outcomes look like, whether or not you're being assaulted or violated, and the amount of violence that Black persons, Black women experience, Black families, the food insecurity that's associated with that, mental health, that issues of poverty. Like there are so many different parts of the experience that Black folks have that are just a lot more extensive. It's always the 2 times more, 5 times more. And it's unfortunate that it's like that, but that speaks more to, again, to our institutions, to our systems, how this world or this country, how these things are created to support and actually to support and invite really Black folks to live here as real people, right? And the only way to come out of racism and to kind of meet racial equity, right, is to kind of follow this model. I thought was a really great example, right? Where we're really looking at like fairness, equal access, equal treatment. We're looking at our own attitudes and our behaviors and our practices. And we're looking at how we're providing unequal treatment, how we're providing limited access, and the disparities that are a result of that, right? We're evaluating our own values and our beliefs and our assumptions, right? We're thinking about the knowledge, information, and exposure to that knowledge to help us to get to a space of racial equity. And we're really determining or understanding that discrimination, prejudice, and stereotyping truly is a thing that most people deal with internally. But how open are we to accept the knowledge and information and exposure, right? And move forward. So for Black perinatal health specifically, I think these stats are stats everybody knows, but Black and birthing women, they are more likely to have severe maternal morbidity and pregnancy-related deaths. We also know that they're also more likely to have fibroids, which also can cause postpartum hemorrhaging, like you guys I'm sure all know. But then we also know as well that they're more likely to display signs of preeclampsia earlier in pregnancy. They experience weathering, and that we know that like the chronic stress, and we talked about this earlier, the association between racism and stress and the stressors that impact someone's life, whether it be the different factors that are impacting them, but really directly associated to healthcare, the discrimination and the racism and the things that they experience over time with that experience, and just generally in their day-to-day lives, also cause a large amount of stress that impacts them in a way that's unlike what anybody truly fathoms. And I can provide an example really quickly. Something as simple as, I'll give a personal example of myself going to see my family doctor years ago, and I actually left after this experience, but the family doctor yelled at me in the waiting room in front of everybody inside of the office because I got there late. And I got there late because I had a family issue, unfortunately. I called, but nobody picked up, as they do not in clinics a lot of the time. But getting there, I think she was just going through something, was having a bad day, but unfortunately she took it out on me. And the embarrassment that I experienced from that, standing in that space, having everybody looking at me, her screaming at me, people trying to understand the situation, myself trying to understand the situation because I was very confused. I'm like, all of these things for me, that was a moment where I realized I can never be in this space anymore because I will never feel safe there ever again. And I'll never feel like I can trust her. And I'll never feel like I can even trust my care to her at this point because she couldn't control her emotions in that moment. And she couldn't control whatever opinion she had of me in that moment. And as a care provider, there's an expectation that patients have, right? Where what patients are looking for is a safe space. And if a care provider is unable to provide that, then I think they have to reevaluate whether or not they should continue in that work. But yeah, so again, just going back to the same stats, I think that we know this as well, that even when Black women have higher income or higher education, unfortunately, they're still having worse care outcomes, right? And that is something we've seen with Serena when she talks about her story, which is quite extensive. And then research continues to show us that as well, right? Like just how Black women are more susceptible, and Black pregnant persons are more susceptible to various complications. And there are various reasons associated with this, some of it unknown, some known, but it's just for you guys to just very clearly understand kind of like what they're dealing with and why care is so sensitive when we're dealing with Black pregnant persons specifically. And this is outside of like their personal experience as an individual, right? That's just what their healthcare outcome could look like. But Black feminism allows us to center the Black experience, which is why I thought it was important for us to bring this up and to really understand the importance of intersectionality and this direct association between racism, sexism, and classism and the other social identities that Black people have, or Black women, Black pregnant persons have, right? And how this engages the inequities that they experience. So I don't know, I think I shared this last year, but I always love to share this because I feel like it's quite extensive. Like this helps us to understand the experience of how governance systems, institutions, how all these things impact the experience or the Black maternal health outcome that someone will have, and all the stressors that are impacted with their life, and how who they are as an individual and all of the different factors, the things that intersect within their lives and their identity, how that impacts their experience and overall their health experience. So this is kind of like a good way to draw from Black feminism and history and all the things we discussed earlier on and how that impacts the experience of Black pregnant persons. And it's also important to remember that we have to reconnect women's health and bodies with the rest of their lives, right? We are forgetting that sometimes. I think that in healthcare, because everyone's so overwhelmed, sometimes we forget that there's so many other things that are truly happening in someone's experience. And within those number of things, that clutter of things, one of them explains why their health outcome looks the way it looks in that moment. And that's why we look to reproductive justice, because reproductive justice, which is the foundation of what Black perinatal health is based on now, or what like advocates are really trying to focus on and push to create space that is more safe and more enjoyable for Black pregnant persons. It's just understanding that, okay, like we have the right to not have a child. We have the right to have a child. We have the right to parent children in a safe and healthy environment. That means we have the right to have the resources that we need to ensure that we can create or live a life that's safe. And we're also allowed, and we should be receiving dignified fertility management, childbirth support, and we should be able to parent together, right, as a fundamental human right. And this is what leads us to cultural safety and why that's so important for that experience, right? Within cultural safety, it's us really recognizing that, okay, we're addressing health inequity being provided like by providing access. Like how we're achieving this, we're ensuring that we're creating inclusive environments, or that we are inclusive. We are ensuring that we are informing evaluations and that we are engaging the ACB community and acknowledging all forms of racism that impact their experience. And we can only do this when we are culturally aware, which allows us to be sensitive, which I don't like cultural sensitivity because I think it's a way to kind of spit in someone's face just a little bit by saying, like, I'm sensitive to yourself. But I think what's more important is being aware more than anything else. And I don't think competency is a great thing either, because we're not trying to be competent. What we're trying to do is get to a space where we can be safe. But it's still a great example of how we get there to cultural safety, and how we get to a space where we can engage patients in the way that they deserve. And so some examples are ways in which that we can move into a space where we're able to create a space that's Black perinatal space that's culturally safe, is that the basic amenities should reflect the community clinic. So that means, or the community that the clinic is in, sorry. So that means whatever location that your clinic is in, or where you provide care, there should be an acknowledgement of the community that's in that space, which means that we're really fully understanding who lives there, what their needs really are, what languages are they speaking, what are the barriers that they face, like what does childcare and childbirth look like for those people in that space and their experiences, and how are we acknowledging that? Interpreters should be available, which I'm sure they always are. You need to go out of your way to recruit and retain ACB staff, especially in communities that have a lot more Black patients. We have to be providing training that's specific to a geographic area, right, and specific to the ethnic group that we're supporting. We need to be coordinating with traditional healers, and not just traditional healers, but just traditional practices, right? There are some practices or some engagements or things that different ethnic groups do in different communities that are a way to bring community together. It's the way that they speak, it's the way that they support one another, it's the way that they share information. So we need to understand those ways and incorporate that within the care space that we have, so that when they come into that space, they feel like that's another safe space where they can actively share their experiences, their health, how they're feeling in terms of their health specifically, and so that we can better serve them. And then we should be working with community health workers, right? And I think that should be a priority more than anything else. Community health work, I think we underplay it just a little bit, and just the efficiency in it, truthfully, and the work that they can really do within a community, and how they can set up clinics and other spaces to be prepared when something like COVID happens, because then they already know everybody in the community and they know how to engage them. So it just makes it easier to get people in the space and care for them in the way that we need to. So that's always really important. We need to address cultural attitudes, distrust, perceived discrimination. So like we need to have no judgment. In the choices that people make, and sorry again for the bullet, but and also in addition to that, we need to consider that the ACB community can experience power imbalances. Sorry about that, and privilege at the same time as oppression. So just acknowledging those things and being aware and listening is the key part in all this. And I'm sure that we've all learned that listening it makes a huge difference. But in addition to everything, we have to consider their economic, geographical, and social factors that impact their ability to access services. And we always use these examples of like the mom who has to watch her kids so she can't come in for her appointment, or whatever that looks like, right? The person who has her in-laws at home and she has to take care of them so she doesn't have time to go in for their appointments, or the person who's dealing with substance abuse and or abuse of any form, and they are unable to commit to something because they don't have the right supports around them, or like there's a million and one different, like somebody who just lives too far, somebody who just doesn't have a car, someone who culturally doesn't believe in, or their family doesn't believe in certain things, like going to see a certain provider. Like there's various things, someone whose partner doesn't believe in them coming in to see a provider because they feel like there's like, I don't know, they have whatever reasons they have, but there are various things that can, or various factors that can impact the way that somebody walks into a space or what they walk in with. So just acknowledging that people or individuals who come in with a variety of different thoughts, ideologies, understandings, and practices and knowledge, and what they're coming in with is what they're leading with. And when healthcare providers kind of shut that down by saying like, this doesn't make any sense, and like what I'm saying makes sense, that's exactly the time in that space where it then becomes a situation where the person no longer will feel safe. And so looking for new ways to engage people and to have discussions and conversations with people so that they don't feel like their entire existence means nothing in that space. Community participation to understand problems with existing services. So sometimes we have all these and especially in Toronto, I think the last few years, or in Canada period, for the past, I would say like 5 to 10 years or so, there was the number of perinatal or prenatal services has dwindled like a lot. And a lot of this really just comes back to the fact that there's an excessive amount of services, people were not using them. So most of the like public health would just get rid of some of these programs, right? More specifically in other provinces. But we need to understand why people are not using these services, right? We can speak directly from Mommy Monitor that people love these services, but they love it according to like in a way that suits their schedule, that suits their lifestyle, that suits their understanding, that's with people that they feel like they feel safe with, that they can interact with, that they understand, with people that they feel respected by. Like it's just, there's more to it than just providing services. It's about genuinely creating relationships and experiences for these individuals. And more than anything, and I think that this is what's going to come up, which has been the bigger thing that people have been focused on right now, respectful person-centered care, and what that looks like. And we're going to talk about that in a moment in maternity care, what that looks like, and cohesiveness, right, between the culturally safe service and other healthcare providers. Are we communicating within a space? How are we sharing that care that kind of touches all persons inside, all professionals in a space, and that's really personalized to each client, makes a huge difference, which is at least what we've seen. And here we're seeing again, like, how do we commit or create a climate for change? And we need to foster humility, which is what we've kind of described already. We need to build trust, which is what I've described already. We need to engage stakeholders, which is huge, because partnerships make a huge difference in just understanding what you guys want and need and who you are, so that when people come in your space, you have the right people coming in so that they can feel safe and heard. And just respect, right? Demonstrating that, and all of this while we implement and sustain change is what creates the huge difference for the client. So respectful maternity care is something that then has come up a lot more recently than anything for the past few years, actually. And the National Birth Equity Collective in the United States, they have been looking at it from the perspective of Black patients in Black perinatal care and what that could look like. And what they talked about specifically is saying that respectful maternity care, it's a call to action to address the socialization of medical professionals, the environment of practice, and institutional accountability. So institutional accountability is huge, right? Because I think the biggest problem that we've identified with our clients is the fact that they feel like healthcare professionals and institutions are not safe spaces because they don't, they're not accountable for experiences that patients feel like they have. So if a patient is saying that, and we've had this more than once, where patients have come to us and said, a surgery happened to me that wasn't supposed to happen, or a procedure happened that wasn't supposed to happen, or I felt this way and I was ignored completely and this was the outcome. Like, all of these things kind of obviously take away from this idea of a respectful maternity care. But what we need to do is create, and what it is essentially is what we're creating and organizing a space for all women that matter, that maintains their dignity, their privacy, their confidentiality, ensures freedom from harm, mistreatment, and enables informed choice, which is huge, informed choice, and continuous support during labor and childbirth, right? And that's what Mommy Monitor, that's what we try to support them with, is like the extra help in addition to their general care. But this is what we're hoping all perinatal care providers will move to in the future, where we're really looking at this extensively and really analyzing ourselves and saying, are we creating a space where when our client, our patients, when they leave, they feel like they have their dignity, where they're experiencing, maintaining their dignity, where they are continuing to feel like their privacy, so they don't feel like data points, and that they actually feel like there is privacy and the confidentiality, and that there is informed choice. So they're being educated about what their choices are, and they're being informed about how to act, how do you move forward with certain experiences? What do you do when you have the option for certain things, right? That is a part of the work that makes a huge difference. So we've seen that in Mommy Monitor specifically, where we do our birth justice workshops and we inform all of our clients about what to know, like, what are your choices as a parent in this healthcare system, right? What are your choices when it comes to a cesarean section? What is your choice when it comes to a breech birth? What is your choice when if your partner is in that room with you and they tell them to leave? Like, what are the choices that are available to you as an individual, and how do you navigate that and work through it in a way that where you feel safe and you feel happy, but where you're also abiding by whatever regulations that institution has. And they talk about the cycle to respectful care specifically, and how providers can get to that space. And it helps them to understand, like, how Black patients are experiencing disrespect, right? And how the patients can be liberated from biased practices and beliefs and structural and institutional racism and the policies that perpetuate that racism. And this is what they've created specifically. So they talk specifically about, like, waking up, which is just like the care provider waking up, or the hospital, the institution, just kind of recognizing the issue, then getting ready, which is really identifying, like, the personal beliefs and your worldviews, internalized oppression and privilege, like all of those things, and how you're moving forward from that. And then reaching out, like, now, how are we now? So, like, knowing how provider biases can influence healthcare services and treatments. And like from there, just going into like, we're looking at something that's internalized and we're moving into how it's interpersonal. And then we're moving into a space where we're then kind of developing partnerships, we're moving into community, and then we're creating real change. And then how do we maintain it after that? And I know this is very small, but so it's hard to see it. But if you guys look at, if you just go on the website, the National Birth Equity Coalition, and you look at respectful maternity care, you'll see they have this there, and it's easier to see. And one of the quotes that they used, which I thought was beautiful, from one of the physicians, and they said that I've been taught as a physician, and all healthcare professionals are taught, that we're the experts in the room, and we're there to support, to provide the expertise to the patient, and they're there to receive it. That's one way, very imbalanced power dynamic that we understand to be problematic. I think relearning how to engage with the person in front of you to who you're offering care is to recognize that there are 2 or 3 experts in the room. And this I thought was key. This is the reason why I shared this. There's a nurse, the doctor, and there's a person in front of you, and they all bring something to the table. And I'll go a step further and even say the doula in the room, or whoever else is in that space, the family member in the room. What really creates a space, and this is something that is really normal within the Black community, family members and people around you are all experts. And it's just the way, even if in your opinion, you're like, no, what you're saying is completely off. But we have to respect that within our families, within our culture, that if the person's in that room, it's because the person who's birthing feels like that person is someone who has some type of expertise and is able to support them. So whatever knowledge they have, whatever that looks like, it's respecting that every person in that space, even the doula, the family member, whoever, then everyone there is an expert in their own right in some way. And everyone needs to be able to come together to support this person, this birthing person, so that they have the best possible experience and the best possible health outcome. And that can only happen when we acknowledge everyone in this space, because then everybody feels respected and everybody feels like they can share more freely and honestly. And that's how you get the information you need to be able to really sort out whether there could be a possible complication, whether there could be something that could possibly turn into an adverse health outcome. The only way you can do that is if you have the right information, because you can't guess it, you can't assume it. Just because someone tells you they're from a certain country, you can't come to a conclusion about what their experience might look like or how they might be eating. You know what I mean? Like, all of these things only come through listening, right? And to get the right type of information, it's creating space where everybody feels like they're respected, and therein creating a space that is culturally safe. And what all this looks like in the end is creating a space where someone feels like they're being seen and heard, where they feel like their humanity is recognized, where they're being informed, which is huge, where they feel respected, where they're making decisions on behalf of their self, where they're receiving early postpartum care and information, where they're being believed. There are so many cases in Canada, in the UK, in the US, like our contracted nurse, like midwives and nurses and people who work with us, where we hear stories of patients who will literally be like, they're pregnant, like I have a headache, I'm not feeling great, but their midwives or doctors or whoever ignore them. And then like we hear 2-3 months later that they've died. And like, this is pretty consistent. So we know that this is a real problem in terms of Black patients not being heard or acknowledged or believed. And that is the biggest thing for me that I want to make sure that I always make sure that I try to bring it across to anybody who's listening to any presentation I do, the importance of just believing and listening, so respecting that they choose their tribe. Like I just said, whoever's in the room, respect those people there and know that they're there for a reason, and just ensuring that they're informed, right? What is the information that this patient, this client needs truly, right? What do they need to know? What is the best way for them to receive support? If you can't be the support, so for example, if they need to be able to call you for if there's an emergency or whatever the situation looks like, and you know realistically that you likely may not be reachable at some point, what are the other things that are being put in place to make sure that this patient feels like they're being supported? What are like I just feel like going the extra mile sometimes, and not everybody does these things. We're supposed to, but not everybody does it. So what are the things being done, or what is the extra mile being taken or the initiative being taken to ensure that patients have the best care experience, right? So we don't have much time, so I'll do one example of one patient we had, and then we'll call it a day. So I'm first just going to give you just some demographics, some basic information about the patient, and then I'll show you a quote that they shared with us. So this is a young woman, she's Somali, she's Muslim, she's a first-time mother, she's also a nurse. She had no complications during her birth. She was low risk. And she had no family with her in the hospital at this point, except for her husband. And this is the quote that she shared. So I'll give you a moment to kind of read it, and then we'll talk about it. So I don't know if people are done. I don't know. I'm assuming. Okay. So this client, her experience was interesting because she was informed. She was a nurse already, right? So she had information, she had tools, she understood kind of like questions she needed to ask. She had the knowledge, right? And all the things that we talked about earlier on. She had support from her husband and her family, although they weren't there at this moment. But she very clearly described that as soon as she gave birth, she stayed in the hospital for a day or two, and then she realized very early on that she was being discriminated against because of her hijabi, because she was a Muslim woman, because she was an East African woman, she was a Somali woman. She realized and she knew it because she heard comments that were being made. It was her treatment that she was experiencing. It was quite obvious she was being targeted, and she understood that. And because of that targeting, she was also being ignored, and she wasn't being taken seriously. And it got to the point where she was in a position where she almost ended up with a very extreme complication that she had to deal with because of that being ignored and because of that experience. So what I wanted you guys to think about and let me know or share right now, have you ever identified similar experiences? And if you were to be in a space where you identified an experience similar to this, how would you react? That's all I wanted to know. That's what I want everyone to think about. And we don't have a lot of time, so you don't have to share. Or if one person wants to share, they can. I can't really see everyone, so you can unmute yourself and share if you'd like to. I think we have time for at least one person to do that, but I just wanted situations like this sometimes don't seem real, I think, to a lot of healthcare providers, because I think most people who work in this space pride themselves in really caring about the patients and caring about this work. But it does happen. So I always wonder, what would you do if you were faced with a situation? If you met her right at this moment and she was sharing this with you personally, what would you do? Or what would your thoughts be? So it's just a thought to let you guys marinate on that if no one has anything to share about it specifically. I wanted to end off with just for some good books that I think that I read and that I think are specific. So mine, The Gap, is a young man made the book, and it kind of analyzes different diseases and complications and issues, illnesses that are specific to the Black experience, right? It's clinical, really good. And then after that, we have Birthing Justice. I have this book, Amazing Reproductive Justice, I have as well. Amazing books. So Birthing Justice will give you very clear examples on like how do you serve and support Black patients. Reproductive justice obviously breaks down reproductive justice and the experience of what that looks like and why it's important to use in care. It'll give you a different lens on how to approach care, perinatal care for Black patients, and how to really understand intersectionality and what that looks like and how the full experience, the holistic experience impacts care. All of these things are things that are important to just acknowledge. And here's our information. If you guys have any questions or if you want to reach out, I see that there is some stuff in the chat, so I'm going to kind of stop sharing the screen and look at that very quickly. Okay, so Erin says that she can't go on camera, but we had a situation recently where a racialized mom lost one of her twins at birth. Oh, that's horrible. And it was just an awful experience at the hospital for her. No one supported her. No one told her what to do or how to get help. Thankfully, we were able to support her to get connected with the social worker at the hospital and encourage her to assist the mom. Yeah, so thank you for that example. So yeah, strongly encouraged. So we can relate to that. Actually, at Mommy Monitor, we get a lot of calls or referrals from these social workers with these moms that go through these situations. So typically what we're noticing now is that when moms get to the point, or birthing persons are in situations like this, and the hospital or the institution really just doesn't know how to support them, they will send them to us, and then our team, then we create a team for that parent to properly support them and get them through this experience. So whether that's mental health support, whether that's just meeting our maternal navigators, which are usually nurses and midwives who can sit down with them and go through situations and explain things to them so that they can understand it more in a one-on-one way. Whatever it is we need to do, whether it's our social worker, whatever it is, we kind of try to create a team to support those parents. But that's a horrible experience. And that definitely happens to a lot of Black parents. Olga as well says, I'd like to ask her the details for what happened. What did she feel? What did she do, say, and what the hospital staff did and said to see the full picture? Is this specific to what Erin provided or the example from the mom that I had in the case study? I'm just wondering what that's about. So until we clarify that, go ahead.
It's Olga. Yeah, it's what I mean. Like, I would like to understand what really happened in that situation. Of course, mom is like sharing the concern, so I would like to know what happened, and then when I see the full picture, how can I support her? Like, and what other actions can be done that the same situation would not repeat, for her or for anybody else. So use that situation like to help mom to understand what maybe like support could be provided for her that she would know, and if she needs to like complain further or bring it up to a certain level, the situation that the next time the next client will have different experience. And also if mom needs some support, how can I support her in that at that time when she already shares that?
No, that's an amazing question. I'm glad you asked that. And that's how I was going to end today, with that information. So the advice that we typically give is, because we know that hospitals and like different institutions honestly are not equipped to provide like a breakdown of like, you need to do A, B, and C to serve this particular, because they go through so many patients who all have so many different backgrounds and they have to kind of attend to everyone, right? So everything's kind of a rush there. So what we typically say is, and this is a little bit of extra work, but if you can get a list of some type of different services that, or at least make sure your social worker has it in the hospital, or that your case manager has it, or somebody in the space has this information that you can share with clients. Sometimes even having a one pager that you can send to clients, if you really can do nothing and you're like, this is out of my depth, like I don't know what to do with this outside of doing the general things, which is reporting it obviously to the case manager, to the manager, whomever, and making sure that the social worker or whomever has the information about the client to help that so that they can support them. That's obviously the first step. Next step is, if they can't support them or if no one in the space can support them, it's having a list of information of other organizations or spaces that can support them. And with that list, knowing like key people, like contact people there. So like if on the list, it's like Mommy Monitor, right? Knowing that, okay, we know that with Mommy Monitor, we can refer out patients. And if we refer them, that they can get like this type of care, and just explaining to the patient that that's what they would get from them. And then checking in at some point once after you've referred them, just to make sure that the patient is getting the support that they need, right? It's our duty to continue to follow up. Follow up is the area where I think we're all failing in healthcare right now, because everyone's so overwhelmed and busy. It's hard to check back in, but that's how we lose patients, and that's how you get them a year later with a worse issue, right? So we're trying to alleviate that and kind of prevent that before it happens. So follow up is what makes a huge difference, because sometimes even for Mommy Monitor, we get so many clients and there's moments where we miss people. It happens, right? We don't want it to, but it does happen. So when that happens, if their social worker or if their doctor or their nurse is not checking back in with us, then it kind of also helps us to be like, oh yes, and then we can jump back in and make sure that client has everything they need to feel supported. But follow-up is huge in all of this. There's no expectation for you to have all the answers. That is not what anybody is looking for. I think, like going back to what we said before, I think if we are informing our patients, giving them information, if we are supporting them, if we're following up with them, if we're respectful to them, if we're sharing knowledge, like if we're doing all these things, we're at least positioning the patient to look into things on their own if they need to, right? We're giving them the tools they need to look into things. We're giving them the support they need to do what they need to do to be more successful with their own care. Because the goal is to create people who are more, or to support people to become more autonomous, and to be able to have the skills and tools to be able to take care of their own care. So I hope I helped with that. But I think the key thing is, if you can like literally just make one day Google, look for different services, make a list, and whenever your clients are having issues, know that you can kind of send them to those spaces. That would make a huge difference. That's a great first step. For the last person, outcome for that client that I talked about, she left. Unfortunately, didn't have a good experience, and that was the end of it. And she just never went back there again. And that's unfortunate. And that's what we don't want to happen, because that creates but now she works harder to make sure other moms don't have that experience. So because she's a nurse, so she's working really hard with that. What are the outcomes of families who choose to put in formal complaints? So we worked on this too. So this is going to be on our new website soon. We're rebranding now. So when the new website comes out, we'll have this. But what we have, I can email my PowerPoint. Yeah. What we're going to have is we worked with some lawyers, a law firm in Toronto, around obstetric violence or trauma, and what are the steps that people need to take in Canada if they are going to report it, all the way to it becoming an actual legal case, because we don't have reproductive lawyers here or any of that kind of stuff. So it's a little more harder in Canada to navigate that, but we have that as well now. So we will be sharing that with everyone very soon, how to do that. But complaints don't work as well. But again, it depends on the level of the experience. And what happened, and also what happened according to the patient and the healthcare provider, and what was captured in the formal process. But yeah, that's all. It's 3:01, so I'm going to stop. Thank you guys for being here today. I hope I was informative. There's a lot more information, so much more. I tried to kind of at least make it so that it was digestible for today. It's still a lot, but I hope you guys took something away from this and you're able to kind of pass it forward. So thank you.
Thank you so much, Elsie. Very much appreciated your time and your insights, and actually had a lot of, if we had more time, things I'd love to dive into. Blanca, I guess I'd like to check in with you if there's anything you're wanting to say.
Yes. Thank you so much, Elsie. I had a quick question.
Sure.
You mentioned the National Birth Equity Coalition. It's US based. Is there anything equivalent in Canada in the works, or that we can expect?
In the works. I'll say in the works. There's some committees that have just been formed. I know one that I'm a part of. And they're just kind of getting their stuff together. There's like 2 maybe now being formed that are for Black patients specifically, and Black perinatal health, like for that, or reproductive health. So you guys, once that's out, I'm sure everybody will find out about it, but I'm always happy to share information once it's more formal as well.
Okay, thank you. Well, I just also wanted to echo the thanks and appreciation from everyone. You've given us a wealth of information and thought-provoking, work that we need to get really involved in. So thank you, and please also thank Shani for us.
Yeah.
She was amazing, the sessions, and we look forward to your website. And I did attend the Racialized Maternal Health Conference, which was
awesome.
amazing. And great sessions again. Great job. So looking forward to more from you that we can share ahead. So,
we have the 2023 Racialized Maternal Health Conference coming up soon. We're planning, it's going to be bigger. It's going to be in person. So I hope everyone's going to be excited for that. I think you guys are really, really going to love it. So yeah, so get ready, everyone. Thank you again for having me. We're always excited to be able to share what we've learned and what we're learning. So yeah, I just applaud you guys for all being here. So thank you.
Cheers.
Thank you so much. And thanks everyone for coming. Good to see you all.
Bye-bye.
Bye.